somebody said before, well, yeah, it's a little confusing because if you're from Montclair, New Jersey, how do people know Manhattan? So since Manhattan is a bit of an international place, you can think of us as Montclair physical therapy. Okay, so injury management and tissue healing. Dr. Rosen talked about swelling of the number of runners in recent years. Well, I'm going to talk about swelling in your joints or ligaments, and what does that mean? So 3 phases of tissue healing. First phase is the acute phase or the inflammatory phase. Anytime you have an inflammatory problem, it's characterized by pain that's constant. It's unremitting. So anybody ever jam their finger? Right? You jam your finger, it swells up, it's painful, and the pain will stay constant because you've built up a sufficient level of chemical in the joint to irritate the nerves. That doesn't come and go. It's either there or it's not. And the acute phase of an injury can last anywhere from 0 to about 7 days. So when your symptoms are constant, they're inflammatory in nature. And Dr. Rosen touched on this. And during the inflammatory phase, what's the treatment? Rice. Rest, ice, elevation, compression. So rest, does that mean you're training for your marathon, you injure your ankle, it's swollen, go to bed and rest in bed for 0 to 7 days, or 4 days, or 5 days. How many people in here are going to do that? I wouldn't do it. Rest is active rest. Well, what does that mean? Active or relative rest means that you're resting from function, but not from motion. You don't want to run, but you want to be moving that joint. Because movement is one of the things, aside from ice or anti-inflammatory medications, that will move that fluid outside the joint, which is where you want it. You don't want it static inside the joint. Okay, so characteristics are swelling, redness, and heat. Does anybody have an injury or ever had an injury where you've had those things? Right. Okay. So when you have an injury that's in the acute phase, relative rest, ice, which reduces the inflammation, compression, if it's really swollen, ACE wrap, and elevation. Keep the joint that's swollen above your heart to allow the fluid to come back into the circulation. Okay, so that's next phase is the subacute phase, and this lasts anywhere from 7 days to 7 weeks. This is where you can have the greatest influence on how that repair starts. Does anybody have any idea about how your body repairs these injuries?
Blood.
Blood. Well, you got to have good circulation. Anybody else? We hear collagen. Anybody know about collagen and what collagen does? Collagen is your body's glue. It's what it uses to repair injury. So let's say you injure your ankle. You twist your ankle. Goes through the acute phase, and now you come to a point where the symptoms are intermittent. Just like going back to the analogy of the swollen finger. You jam your finger, it swells up. First few days, it's constantly painful. After a few days, you bend it. Ow, that hurts. Ooh, that's better. Ow, that hurts. That's better. Now it's starting to become mechanical because there are periods of time where the symptoms can abate. During the mechanical phase of an injury, this is where you can have a great influence. This is where you're going to start moving it. Collagen, it doesn't know how to repair itself. It heals along the lines of stress. So I'll give you an example. Does everybody know what this is? Right? Stocking. Collagen heals or moves exactly like a nylon stocking. So if you look at this nylon stocking, it has a nice stretch to it. And the reason it has a nice stretch to it is because it's in a weave or a knit. So you pull it, and the weave stretches. Collagen is the same way. If you've injured a joint, or a ligament, or a muscle, and you don't move it, what happens is the collagen is laid down rapidly, especially during this acute and subacute phase. The collagen will be laid down in a thick and fibrous, inelastic way, where it doesn't have a lot of stretch. A single strand of nylon has almost no stretch at all, but you put it in a weave and it has a nice stretch. Collagen works exactly the same way. If you start to move that joint, while it's repairing and this collagen is being laid down, it'll be laid down in a weave or a knit so that it's conducive to normal motion. So this is your opportunity to make sure that that repair process is complete, and the tissue that's being repaired most closely will resemble normal tissue that was the way it was before you've injured your joint. Okay, so characteristics of subacute phase. Symptoms are always intermittent in nature. However, these symptoms can go back and forth. You start training too soon, right back to where you were in the inflammatory phase. So you can set yourself back by starting too soon. And we'll talk about the idea of training submaximally without overshooting your base. Limitation in range of motion. Pain is produced with movement. When the movement stops or below your end range, the symptoms go back to their baseline. So how do you know you're safe? You provide a stretch, produces a symptom, but it doesn't remain worse as a result. Then you know you're safe. So the treatment here is a controlled intermittent stretch, and there's been a raging debate in the literature for years now about whether you sustain a stretch or don't sustain a stretch. So how many people in here stretch? Right? Excellent. When you do a stretch, do you sustain it, or do you do a pressure on, pressure off? Sustain? For how long? 30 seconds, 10 seconds, right? We're all over the board, right? Okay. So, for a healthy structure, you want to sustain for 30 seconds, you want to sustain for 20 seconds, that's fine. For an injured structure, let's say you injure your hamstring muscle. You're going back to stretching, and you sustain the stretch for 30 seconds. You're in the subacute or the chronic phase. You do your stretch. After you stop stretching, it remains painful. Half an hour, hour and a half, 2 hours, 4 hours, 8 hours a day. What's happened? You've now made a mechanical problem an inflammatory problem. You've set yourself back. So here's a really simple thing that you can follow. If you've injured a muscle or a ligament or a tendon, and you're going to do a stretch, much safer to do a controlled intermittent stretch than it is to do a sustained stretch. Why? At the end of the day, both stretches will get you to the exact same place. The literature is really clear on this. Intermittent stretch produces a symptom, because you got to produce a symptom, otherwise you're not going to stretch it far enough to create a change. When you let off, the symptoms go back to their baseline. You've stretched it far enough to create a change, but not so far that you're going to injure it. One's a crapshoot, one's safe. And at the end of the day, they both get you to the same place. Okay. Chronic phase, or remodeling phase. After an injury, this can go on, depending on the severity of the injury, up to a year. So you start to do your controlled intermittent stretch during the subacute phase. During the remodeling phase, you want to keep doing your stretch or your exercise. You don't want to stop. Because when you start doing your activity again, you want to make sure that those structures are intact. And you continue to influence the way that collagen is being laid down for up to a year. So you want to keep doing that stretch or the exercise, whatever it is you happen to be doing. Okay, so Dr. Rosen talked a little bit about threshold, and when you come back from injury, your threshold is going to change. It's going to come down. So how do you know what's safe? Well, Dr. Rosen talked a little bit about the 10% rule. It's a pretty good guide for you to use in terms of prevention and re-injuring. So you're not going to increase your frequency, intensity, or duration of activity by more than 10% a week. Why? You're going to give the structures that have been injured, the ligaments, the muscles, the tendons, the joint, a chance to accommodate to the stress that you're asking it to take. And that way you'll be safe. And then the last thing I want to talk about is a traffic light guide. We use this quite a bit. Very simple guide, and I'm from New Jersey, so you don't want to use a New Jersey traffic light because no good is going to come to that. So the traffic light guide says, if you do a stretch or an activity that produces a symptom and it remains worse for more than 15 or 20 minutes afterwards, red light, back off. If you do an activity that produces a symptom and it goes back to its baseline after you finish, it's a yellow light. Just proceed with caution. You do an activity that decreases the pain, increases your function, that's a green light. Go. So, those are the principles of tissue healing. Let's apply that to one of these injuries so that you can see that during the course of your recovery, if you happen to be injured, that you can apply these principles safely and accurately. So one of the common injuries that we see is plantar fasciitis. Has anybody here had plantar fasciitis? Yeah, marathon runners don't ever get that, right? You've had plantar fasciitis, Dr. Rosen?
Really briefly, after running on the sand.
Yep. Okay, so how do you know you have plantar fasciitis? First thing is you step out of bed in the morning, exquisitely painful, right? Some people come into the office and say, oh, look, this hurts so much, I'm afraid I'm going to die. Now it's lasting so long, I'm afraid I'm not going to die. You have to do something. So, used to be, you send somebody home with a stretch, they do the stretch a couple of times a day, ultrasound, electrical stim, all of these passive modalities. Well, about 10, 12 years ago, there was a great article in the literature by this Swedish physician named Alfredsson, and he was a runner. He still is a runner, and he had this plantar fascia pain, and he went to see one of his colleagues in the orthopedic surgery department, and in addition to having plantar fascia pain, he had pain in his heel cord. So what did he do? He said to his colleague, look, I want to keep running, I don't have time for this, just do surgery on my heel here. And his colleague said, I'm not doing it. He'd go to physical therapy. He said, don't have time for that, just do it, I want to get back to running. He says, not going to do it, got to go to physical therapy. Now in Sweden, they have very good musculoskeletal medicine, and so he goes down to the physical therapy department, and they put him on a slant board to have him do eccentric loading of his Achilles. So does everybody know what eccentric loading is?
No.
All right, so it's a lengthening contraction. So let's say I take a 10-pound weight and I put it in my hand, so my biceps muscle and my brachioradialis muscle are holding this weight up. If I slowly bring it down, that muscle is lengthening, but it's got to control the descent of that weight. So the literature tells us that eccentric contraction of a muscle can be much more effective in strengthening and lengthening his muscles. So they told him in physical therapy, you got to do this eccentric loading of your muscle. So he does it for a couple of days, back to his buddy, says, I don't have time for this, cut me and fix this. He says, not doing it, haven't given him enough time. So he says, great, I'll show them. I'm going to bust this. I'm going to wail on it and bust it, and then they'll have to fix it for me. So what does he do? He goes on the stair, and he just, entire body weight, just wails on his ankle. 3 weeks, symptom-free, gone. He gets very interested as to how this happens. Well, think about this muscle. Dr. Rosen said, this is one of the prime movers in running. It takes your whole body weight and propels you off the ground and forward. It needs to be very strong. So this tendon is huge. In order to stretch it, or in order to load it, you have to apply a huge amount of force. So they did study, and they did a controlled, randomized, double-blind study, which is very, it's one of the top studies that you can do. And what they found was that eccentric loading of these large tendons frequently over the course of short duration, could be 3 weeks, 4 weeks, and these symptoms start to abate. These are very strong structures, and you need to load them functionally, which means with your whole body weight. So, and if you look at the way these injuries occur, with plantar fasciitis, generally at the beginning, they're constantly painful. No positions, no movements will have any effect. After about 3 or 4 or 5 days, they start to become intermittent. You step down on the ground in the morning, it's painful. The more you walk, the better it gets, or the more you run, the better it gets, and as you're running and you're thinking, oh, my foot feels great, wonderful. You stop, go home, you take your shower, you sit down, you watch the Olympics, you're there for a couple of hours, you get up, oh, this is killer. Or you go to sleep and you wake up in the morning and it's right back to where it was. You're in the subacute phase because the symptoms are intermittent. When you start, if you leave this long enough and you go to the chronic phase, 6 weeks, 8 weeks, 10 weeks, 12 weeks, it takes longer to get these symptoms to abate. Why? Because the remodeling process is going on. You've laid down this thick, fibrous, and inelastic tissue, and now you have to remodel that tissue, or you have to go all the way back to the inflammatory process and start over again. So, and then the common questions that we get in our clinic is what's the difference between a sprain versus a partial tear versus a complete rupture. This is really interesting, and this work was done many, many years ago. If you have an injury that's, let's say you injure your foot, and your ankle is strong and painful. Well, what that tells us is if it's soft tissue, that there may be some micro tears in the tissue or small disruption in the tissue. If it's painful and weak, that means there's a major disruption in the tissue. If it's painless and weak, that's a full disruption. That doesn't seem to make sense, does it? Why would it be painless?
Nerve damage.
Yeah. In addition to tearing the tissue, if you completely tear the tissue, any of the nerve endings that have been connected as well, they're torn. Anesthetic injury. You'll get inflammation, and you'll get ache and soreness from an inflammatory response, but the tissue itself, it's anesthetic. So, strong and painless, nothing wrong. Strong and painful, minor disruption in the tissue. Weak and painful, major disruption. Weak and painless, that's a problem. So, and I guess we take questions after.
Yeah, we're gonna
Yep. Yep.
finish up and,
Yep. Great.
and now we will open it up to some questions for about 5 or 10 minutes, and then, we can, hunt down people. So Dr. Rosen and Todd will both address questions. Yes?
To either one of you as experts, how do I avoid hamstring cramps at like mile 21?
Get to mile 26 as fast as you can.
Not a nice area, I have no one.
Do you want to take that?
Sure, yeah. Well, I mean, first of all, mile 21, usually you're going to see more quad cramps. It depends on who you are, everybody's different, but a lot of times you're going to see more quad cramps for that same reason that your quads oftentimes are somewhat underdeveloped, and when you're really pushing things, towards the end, the quads sort of can become the weak link in the chain. Hamstrings can be an issue too. Cramps can come from a number of different factors. They can come from simply being muscles that are too tight. You can get spasms of muscles that happen. A lot of times they're just the body's sort of first way of giving out. I mean, essentially what happens is when you're running, you're using your muscles, you're running through all of the stores of, you know, of, I don't know the best way to put it, but, you know, basically cramping is oftentimes a sign that you're getting near exhaustion of any, you know, perspective, and that can, you know, can happen early, it can happen late, depending on your level of training. Usually it's a sign that you push things a little bit too aggressively, whether that's a 6-hour marathon for somebody or a 3-hour marathon is another thing. Obviously maintaining good hydration during the race is important. Maintaining good sodium can be helpful, so making sure you're taking something that's got sodium in it, whether it's salt tablets, whether that's gels or some other type of materials, you need to maintain that as you go. And just maintaining adequate calories. I mean, during a race, especially if you're running one of these things for a fairly long period of time, you need to maintain some pretty good calories. I mean, I run these things pretty fast, but I still will maintain at least five gels during the race to make sure that I'm getting some calories in me as I go. And if you're going to be out there for a lot longer than that, you probably should be eating more than that, because it is it's a long time as you go. Not a great recipe for it. I mean, a lot of times it just comes down to the training. You know, if you're getting cramping at mile 21 during a training run, and that's a sign that during the race you may develop the same problems. So you just got to really take stock of your training and make sure you're training at a level that's adequate for your level of speed, basically.
Hydration and nutrition. I think it's really interesting because if you ask elite runners and it's how they run 2 hours and 30 minutes from the marathon, wow, or 2:15 or 2:06, and the elite runners will say, that's easy. I don't see how people stay out there for 4 hours. If you're active for 4 hours, you need to be drinking. You need to be restoring your nutrition. It's really important. So I don't think there's any magic bullet for that.
And we'll talk more about that with your coaches and things like that. We'll definitely cover it. More questions?
I actually have it might seem unrelated, but in my head it's related. You mentioned runner's knee, but I don't exactly know what it is. And this is a follow-up to what you said about, so what do you do when you have minor pain but strong knee? Or whatever? So that's, do you understand where I'm going with that?
And then I'll give my
Yeah, I mean,
perspective.
again, runner's knee typically is going to be pain that's occurring in the front part of the knee. It typically follows a pattern where it's sore for things like kneeling, squatting, going downstairs, running down hills, sitting with the knee bent for a couple hours in a session like this or a movie theater or something like that. It's caused by typically a weakness of the inner portion of your quadriceps combined with some tightness of the outer portion. That's a little bit oversimplification, but that's sort of the usual causes. And typical treatment is, besides the usual stuff in terms of anti-inflammatories and such, it's usually a combination of strengthening the inner portion combined with some more aggressive stretching for the outer portion. A lot of people will get some mild variants of it. I mean, I'll get a few aches when I'm running down a hill if my muscles are tired and I haven't been doing as much workout as I should be. But it can become pretty debilitating. It can become pretty painful. So that's kind of the condition as far as the treatment goes. Therapy is the mainstay of treatment for it.
I'm going to really oversimplify it now. So we see a lot of people who come in with patellofemoral pain, which essentially means pain in the front of your knee. Doesn't give us a real good indication of exactly what it is or why it's there. And as Dr. Rosen said, what we see typically is people come in, they're doing a lot of eccentric loading, going downstairs, running downhill. This is typically where these things start. And then you might sit for a while. And as you sit, your knee gets kind of achy and you try to stand up and it's stiff and it's painful. Right? That's mechanical, because position and movement have a direct effect on this. The way we look at that problem is we say, okay, what positions and movements make this symptom worse? So I'd ask you a lot of questions about what you're doing during the course of the day or what activities that you do that exacerbate your symptom. And then we'd move your leg in different positions to see what movements have what effect on your symptom. So I always use this example. You ever get a pebble in your shoe?
Yes.
Okay, so you get a pebble in your shoe and you step down on it, and if it's in a place where it's not so pleasant, like your heel, it's going to be painful. And every time you step down on it, it's going to be painful. It's going to inhibit the way you move your foot, and it'll alter the way you function. Well, if you can't take your shoe off and you've got to get somewhere, what would you do? You could limp, or you might move your foot around until that pebble goes to a place where it's not pressing on something sensitive. Right. Many times these happen in joints, and what we see very frequently, especially somebody with a runner's knee, where certain positions really exacerbate it. I'm sitting, and I keep it in one position for a long time. I'm at my desk, and then I go to get up. My movement is limited, and it's painful. Just like that pebble in the shoe, what positions and movements alleviate those symptoms? What we find many times, and it's not always, because sometimes there's other directions, is knee extension with overpressure, consistent, repeated knee extension with overpressure will alleviate the symptoms. You do that frequently enough throughout the course of the day, over days, over weeks, these symptoms start to disappear. So in our clinic, we don't use a lot of modalities. Ultrasound, hot packs, electrical stim, these are passive types of intervention. The literature is pretty clear about the fact that these passive interventions for musculoskeletal problems actually can delay the healing process, because the healing process calls for an active movement. These joints are made to move. And the passive interventions generally are not what's going to take the pain away. And as Dr. Rosen said before, look, you go to a physical therapist and they put a hot pack and electrical stim on your leg. Okay, so you heat your leg, you cook it, and you electrocute it, and then they send you on your way. Nothing's going to happen. That's like spitting into the wind. These joints want movement. Certain movements, especially repetitive movements, can cause these injuries. Other movements can be healing. Does that help? Yep.
Scott?
Can you just quickly address post-run and the day or two after, as far as IT issues go? What you should do immediately after, and what you should do at home then for the 24 to 48 hours after?
I mean, assuming you have some IT band symptoms, that's okay. If you don't have IT band symptoms, then obviously doing some basic IT band stretches after the run, this kind of stretch is sort of one of the more common ones that you do. It can certainly, can be helpful somewhat in terms of prevention. If you do have IT band syndrome, the ice definitely a big thing. So either getting some type of an ice or cold wrap device. I'm not a huge fan of ice by itself. There's about 100 different things on the internet that you can use to basically cold packs that fit around the knee joint in a pretty controlled fashion, and they'll let you walk around for half an hour with the thing on there. It can be very helpful for it. You can throw a bag of ice or frozen peas on it, but it's not so easy to manage. So ice definitely very helpful after runs, not before a run, but afterwards can be helpful. For a couple of days after a run, obviously the important thing is recovering. So you want to take a time, if you've got some issues, you want to take a day off between running so that you're not repeatedly beating it up if you can in terms of your training schedule. And light stretching through the course of the day, I think, is much more helpful than trying to stretch everything out in one 15-minute session right after you run. So, doing one stretch now, right after the run, then 2-3 hours later, doing a nice stretch for that, 2 or 3 hours later, waking up in the morning, in the shower is a good time to do it. That's when kind of heat can be helpful for it, because it kind of helps loosen things up. So in the morning, stretching things out when they're tight can be very helpful, both before a run and even before you get around in your day-to-day activities. But again, if you're having consistent symptoms, and a lot of times the IT band isn't just the issue, it's not just tightness right there that's a problem, it's oftentimes the whole chain. Something's not right, whether it's tightness up and down the whole chain, or sometimes some muscular imbalances that really need to be corrected. So if it sticks around, that's again where the domain of a good physical therapist comes in, to look at all that and figure out where the problem lies.
The symptoms are constant, they're inflammatory. You don't want to stretch them. Is it? Rest. Ice, very effective. When the symptoms are intermittent, then you start to stretch them. And again, controlled intermittent stretch every few hours. You do a few stretches over the course of a few days. But if the symptoms are constant, they're inflammatory in nature, and if you try to stretch at that point, you're gonna make it worse. Yeah. And at that point, you don't wanna add heat to it, because the body's already put heat there. So adding more heat to an already inflamed joint is not gonna be so helpful. But
I was sidelined from running for a while because of Shin Splint. So now I'm really afraid to get it again and having the marathon coming soon. So what can I do to avoid it? Right now I'm also running with compression sacks. I don't know if they are good, but
do you find that to be helpful?
yeah, it's
And
holding. I mean, when I am running, at least it's not moving, so it's
Yeah.
more compressed. So I think it's helping me.
Right. So does everybody know what shin splints are?
Yeah.
You know what it feels like, right? So shin splint is just the muscle here, the tibialis anterior, that pulls your foot up, which you need to do when you're running so you don't trip. Your foot has to come up. This muscle gets really strong. And what happens is you have an outer layer of bone over this here called the periosteum, and you have a lot of nerve endings in the periosteum. So the muscle up here, the tibialis anterior that pulls your foot up, is connected to that periosteum. Sometimes it can get so strong when it contracts, it pulls the insertion or little pieces of that bone away, and that's the pain you feel. Right? You can start to get really severe types of problems that become it's called anterior compartment syndrome, and then you need to get to the doctor, because that's a big problem. But in terms of shin splints, are you doing your stretching? Okay, so your controlled intermittent stretch enough. You want to monitor the symptoms. If you start to get symptoms when you're running, you either have to monitor the way you're running, the surface that you're running on, or your training program, because a lot of times these types of injuries occur from increasing too fast. You're increasing your frequency, intensity, or duration too much. Overtraining can be a big problem, and that's one thing that reminds me I wanted to mention, just to follow up on what you had mentioned. Overtraining, far worse than undertraining for a marathon. Because most of the time, you're not going to make it to the marathon if you overtrain. And you know, we can talk to the coaches over here, because they know they've had lots of experience over a lot of years in running at an elite level. And overtraining is many times what can cause these types of overuse injuries. So you want to stay below that threshold.
Time for one more question, which I think you had a question over here.
Yeah.
Okay.
Can you actually describe what exactly plantar fasciitis is? And I guess to clarify the anecdote you gave with the gentleman who put the weight on the stairs, I mean, what exactly was what did he arrive at conclusion was?
All right. So plantar fasciitis means an inflammation of the fascia on the bottom part of your foot. So if you think of your foot as kind of like a spring, the arch in your heel goes like this. Here's your heel, here are your toes. You have a thick band of fascia or connective tissue that sits right between the bones before your toes and your heel. When you step down, your foot is a shock absorber, and that fascia stretches. If you stretch it too much, or you overuse it, what can happen is, just like we talked with the principle of tissue healing, you can create an inflammatory process. The fascia can thicken, and as it starts to heal, you create these thick fibrous bands of connective tissue. And every time you step down on it, let's say you go to sleep at night, you're sleeping for 8 hours, and all this connective tissue is being laid down. You step down on it in the morning, it's really painful. As you're walking on it through the course of the day, you're starting to remodel that tissue, and it's starting to get a bit of a stretch to it. Back to sleep. Same thing happens again. So you have to interrupt that. And the way you interrupt that is by loading it as much as you can. Does that help?
Yeah.
Yep.
Last minute questions?
Wants to ask?
I
Actually, I have another question, if we have time. Can somebody change their foot strike from overpronated to neutral, and is that helpful?
Well, changing foot strike, the one question that nobody's asked so far is the one that almost everybody asks, which is, should I be running in bare feet? Why, and everybody running in bare feet if you read the book about it. I mean, changing the way you run is a difficult thing to do in terms of, I want to change the way I'm running down the street. It's something we learned how to do as a kid. It's something that everybody does naturally, and to make an effort to say, okay, I'm going to kind of change the way this goes is very, very difficult to do, and it's usually ripe with trouble. And I've got lots of patients who come in, I'm like, so why did you start having pain? Oh, well, I started trying to do midfoot striking because my coach told me that's all I needed to do. And in the reality of it, it's not easy to accomplish. There are basically two main elements of running in terms of the way your foot goes down. One is pronation and supination, which is how your foot shifts side to side. Some of that is built into you. That's just how everybody is. Some people have a tendency towards their feet splitting to the side. That's called pronation. Some people either supinate or are very neutral. Some of that can be controlled by simple running shoes. You go to a running store, who's going to put you on a treadmill, they're going to watch you, and they're going to see how much pronation and supination, and presumably put you in a shoe that's appropriate for you. And some of it is controlled by the shoes themselves. If you're running in regular running shoes, neutral or control type shoes, and the shoes start to wear out, slowly your foot slides to the side. Even before the shoes are all beaten to hell, the shoes will basically dial in their own pronation and will force your knees into a position that's no longer very nice. So it can be either external based on something that you're doing, or just built into you. So in general, orthotics can control that, so custom orthotics can control that, different types of shoes can control that, but you really can't control that based on how you run. So basically how you run is the way you run, and you cannot just subtly change the way you run to do that. Midfoot striking, forefoot striking is sort of one of these new hot topics on where your foot should land in terms of how it rolls. Also very difficult to accomplish in terms of the way you change the way you run. I know some runners that have tried it, and some have succeeded and some haven't, but pretty difficult. I mean, that you can actually physically think about it, and I'm just going to start striking more on my heel or on my forefoot or somewhere in the middle, and you can accomplish that. The problem is, can you maintain it, and should you maintain it? Is of any real functional difference? Personally, I don't think that there is a lot of that. Now, there is a new trend towards running shoes, which are these midfoot striking running shoes, and the shoes are designed so that when you land, the midfoot lands first. They've got a little sort of a curve to them almost. Skechers is the one that came out with it. Neb is the guy that's sort of promoting it to a certain extent, although he's not even behind it in terms of like going crazy about it. So that is a different story, and a bunch of these companies now have these sort of midfoot striking shoes. Nobody's done a good control clinical study, in my opinion, to prove who would benefit from this, who wouldn't benefit from it. There probably are some groups of runners who have a tendency towards having problems that might benefit from it, but so far nobody's really done a study on it. Same thing with the Vibram 5 fingers who are running plain barefoot, which I think is absolutely nuts in Central Park, but I see a couple of crazy guys doing it with tacks and glass and dog poop around. It doesn't make much sense to me, but even that, I mean, running on a hard surface and minimalist shoes, to me, just doesn't make much sense for anything other than a race when you're looking to have a pair of speed shoes that is light. But for training purposes, to me, running shoes are designed for what we do, which is running on pavement for the most part, or dirt trails or things like that. I think if you live in the wilderness of Mexico, then probably running in minimalist shoes is probably perfectly fine, because that's what your feet get used to, and it's the way that you develop. But for here, it doesn't make much sense to me, despite a very colorful and interesting book about it.
Isn't there some statistic like 60% of injuries are caused by the wrong shoe?
The Born to Run book that everybody asks about, and is a very interesting and colorful book, makes all kinds of points about how running shoes really haven't changed enough, and that nobody wants to make these shoes safer, and that the shoes in general are probably responsible for lots of injuries. I don't really think that most of the conclusions that were made in that book really had any kind of real major scientific backing behind them. I don't think that running shoes necessarily are so much safer than they used to be. I also don't think that running shoe companies necessarily have safety in mind when they're making them bright pink and bright yellow and really trying to make people look at their shoes versus the other shoes that are on the shelf. So I do think there is some truth to that, but at the same time, I do think that the way these running shoes are designed is that they're designed for what we do, which is run long distances on a mixture of pavement and dirt, and they're designed for different people. So these companies come out with a wide range of different shoes that are designed sort of address some of these issues for people who have different, running styles. So, I think that there are lots of people that could run races in almost or run anything in whatever shoes there are, and there are other people that have to have very rigid orthotics with very, tight control of the way their feet strike. Most people are somewhere in between, where if we put the completely wrong running shoes, then running long distances would definitely screw us up. But if you get something that's reasonable, then it doesn't have to be something crazy perfect. I have a podiatrist who makes lovely orthotics. They're fabulous, and I send some patients to them all the time. I can get free orthotics. I could get 10 pairs if I want to for every pair of shoes I own. I run in over-the-counter just plain running shoes, just what's in the running shoes that are out there. So, I think that certain runners benefit from orthotics. I think they're very helpful. I personally don't have feet that I think have any real benefit for them, so I choose not to use them. But it, it's something that is widely used.
Just one more point. Trying to change the mechanics of the way you naturally run, or trying to change the mechanics by putting in an orthotic or completely changing the shoe that you're running in, that's when you get injured. It's like trying to change your stride is like trying to change a career. They're very difficult. It takes a long time, and if you try to do it in a short period of time, that's when you get hurt. So these rapid changes that cause the injury.